classification systems are used to describe anemia. One is based on the cause, such as acute or chronic blood loss, red blood cell destruction or malfunction, and red blood cell production or maturity. And the other classification is based on the size, the color, and the shape. An example of size is macrocytic anemia associated with hypothyroidism. An example of color is hypochromic or pale nature of red blood cells in iron deficiency anemia, and shape such as the spherocytes seen in autoimmune hemolytic anemia. The United States Preventative Services Task Force recommends routine screening for anemia only in women who are symptomatic or when pregnant, although it is reasonable to screen asymptomatic, non-pregnant women every 5 years in a low-risk population. Consider routine screening for those at higher risk for anemia, which includes anyone with heavy menstrual flow, chronic diseases, and those with poor nutritional intake. Symptoms of anemia, depending on the cause and severity, may include pallor, racing heart. Clinically, this is as high as a rate of 120, decreased tolerance for exercise, dyspnea, and dizziness. Fatigue is often associated with anemia, but it's uncommon unless anemia is severe or sudden. Symptoms are more pronounced in those with lower hemoglobin and hematocrit levels, acute onset, as compensatory mechanisms have not had time to develop and catch up, or those with severe underlying disease. With chronic anemia, compensatory mechanisms have had time to develop, and therefore women may not be symptomatic until red blood cell levels reach critically low levels. We'll briefly review the most common microcytic anemias seen in primary care. The first is iron deficiency anemia, or IDA. IDA is the most common anemia in the world. In the US, most common cause is insufficient dietary iron intake, decreased iron absorption, and increased blood loss. Example again would be heavy menses. In developing countries, IDA is most common in tropical regions. It's caused by hookworms and it's subsequent to intestinal blood loss. IDA onset is gradual, with red blood cell production falling in response to declining iron reserves. As a provider, you'll order labs and find the following values to be low: hemoglobin, hematocrit, reticulocyte levels, and serum ferritin. Transferrin and total iron binding capacity will be high. Treatment for IDA is iron supplementation, and there are many forms of iron supplements. The provider should consider both absorption and side effects when discussing the options for your client. Absorption is maximized when supplements are taken before meals, but common GI side effects do include nausea, diarrhea, heartburn, constipation, and tarry stools, which you should educate them about. People who are supplementing should be educated regarding impaired absorption and should not take iron supplements with calcium. So those found in dairy products, tannins found in tea, phytic acid, which is found in cereals, grains, legumes, and nuts, and antacids or H2 blockers. Absorption is increased when taken with vitamin C, such as orange juice. Providers should plan to recheck hematocrit and hemoglobin levels after 2 to 3 months of treatment. Let's move on to thalassemia, alpha and beta. Functional genes are necessary for the production of both alpha and beta chains. Genetic malfunctions can lead to thalassemia, either alpha or beta, depending on the chains affected. Most alpha thalassemias are due to deletions within the gene clusters, but some are due to genetic defects. Beta thalassemias are inherited disorders. Testing should be offered in pregnancy, particularly for those with ancestors originating from the Mediterranean or Southeast Asia due to the prevalence there. If positive, genetic counseling should be offered for the couple. Let's move on to macrocytic anemias. The most common cause of macrocytic anemia are nutritional deficiencies, such as vitamin B12 and folic acid. Alcoholism is also a differential to consider in the presence of any macrocytic anemia. Less common causes are hypothyroidism, leukemia, myelofibrosis, multiple myeloma, and drugs that affect DNA synthesis, such as chemotherapeutic agents. Folic acid deficiency anemia. Folic acid is utilized to produce red blood cells. Insufficient levels can be subsequent to inadequate intake, which is seen in infancy, among the elderly, and then those with alcoholism or other malabsorption problems due to gastric surgery, as an example. Or increased need, like we see in pregnant women and women who are lactating. Or increased loss, such as hemolytic anemia, cancer, dialysis, or inflammatory diseases. And medications. Those include methotrexate, trimethoprim, and any anticonvulsant drug. So management for folic acid deficiency includes supplementation and increasing dietary intake of foods such as eggs, meat, leafy greens, milk, mushrooms, and yeast. Bread in the U.S. is commonly fortified with folic acid. Absorption is also dependent on vitamin C. Vitamin B12 deficiency. So vitamin B12 is necessary for the production of red blood cells and the maintenance of healthy nerve cells. Insufficient amounts can lead to fatigue, shortness of breath, difficulty walking, and diarrhea. Neurologic symptoms frequently lead to testing and ultimate diagnosis. Insufficient B12 can be due to inadequate intake, as we often see in someone with a vegan diet, intrinsic factor deficiency, pernicious anemia, or post-gastrectomy. Small intestine diseases, we think about those with Crohn's disease, tapeworm, and again, malabsorption issues. Moving on to pernicious anemia. This is also known as autoimmune gastritis. It's one of the most common types of vitamin B12 deficiency anemia and results subsequent to a lack of intrinsic factor. Intrinsic factor is a protein produced in the stomach needed to absorb vitamin B12. The course of pernicious anemia is slow, and therefore the average age at diagnosis is 60 years. Pernicious anemia requires lifelong treatment and is managed with both parenteral and high-dose oral supplementation. Normocytic anemias are those where the MCV remains the same, but there is a drop in both hematocrit and hemoglobin. Normocytic anemias are most commonly caused by blood loss, inflammation, or chronic disease. Those normocytic anemias can eventually lead to a microcytic or macrocytic anemia due to depleted iron stores or the presence of immature RBCs. Hemolytic anemias are those that are due to a decreased number of circulating red blood cells due to premature destruction. Hemolytic anemias can be classified as either intrinsic, such as thalassemia or sickle cell disease, or extrinsic due to immune-related causes, drugs, microangiopathy such as preeclampsia and HELLP syndrome in pregnancy, or cancer and infections. G6PD is an X-linked genetic disease that affects the G6PD enzyme. This enzyme is responsible for blocking the effects of oxidizing agents on red blood cells. Without this enzyme, hemolysis occurs. Sickle cell anemia is inherited from one or both parents and involves a sickle gene mutation on the beta chain of hemoglobin. Sickle cell disease occurs when a child inherits the gene from both parents. A child can carry the sickle cell trait when one parent passes it down. Individuals with sickle cell anemia have a lifespan that is generally shortened by 25 to 30 years. Individuals with sickle cell trait generally have fewer red blood cells that are affected, resulting in fewer symptoms. Individuals with sickle cell disease can develop significant complications, resulting from the large percentage of red blood cells that are affected. A healthy RBC lasts about 120 days, while red blood cells in sickle disease last for only 16 to 20 days. Red blood cells are not produced quickly enough to keep up, and this is what results in chronic anemia and hypoxemia. The red blood cell in sickle disease also adheres to the vascular endothelium, resulting in vascular obstruction. Resulting cell injury leads to chronic low-grade inflammation and tissue hypoxia throughout the body and eventually causes organ damage. The hallmark of sickle cell disease is painful sickle crisis, resulting from tissue infarction, acute inflammation, and severe anoxic pain. The most commonly affected sites are the limbs and the abdomen and can last for hours or weeks, requiring hospitalization and pain medication. Approximately 50% of adults with sickle cell disease report mild to moderate pain that remains between crises. Women with sickle cell disease are more likely to have complications in pregnancy. Therefore, contraceptive counseling is critically important so they're able to plan desired pregnancies. All contraceptive options, including those that are hormonally based, are safe for individuals with sickle cell disease.